Hey BMSA, my name is Megan Giles and I'm the media chair. First and foremost, welcome to our second general meeting. And if you haven't already, make sure you're following us on social media at BMSA_BU and get your committee applications in by Friday, the 26th. This week we have an amazing speaker, Dr. Hurley, but first a word from the officers.
Hi, everyone. Welcome back to another general meeting. My name is Delaney Hsu, and I'm BMSA's president for this semester. Just a quick reminder to get your 50 points in this semester, 10 of those coming from service events and 10 of those coming from academic workshops. As Megan mentioned, our committee application deadline has been extended, so make sure to get those in and send those to your respective officers. Thank you guys and enjoy the meeting.
Hi, everybody. My name is Sarah Jones, and I'm your service chair this year. I'm very excited to announce that we will begin in-person service events this week. All of these events are in addition to our online events, and we will be adhering strictly to COVID guidelines at all in-person events. Remember, you need 10 service points this semester, which equates to 2 hours of service. I'm so excited to have a hands-on semester with the Waco community, and I encourage you to check out the sign-up sheet and get involved.
Hello everyone, my name is Aman Patel and I'm the Research and Internship Chair. We have great new workshops lined up for you in the next 2 weeks. The undergraduate research panel is on February 24th at 6 p.m. and how to read a diagnostic scan at 7 p.m. Surgical operations is on February 26th at 6 p.m. Scribe EMT-MA is on March 1st at 7 p.m. and on March 5th at 6 p.m. We also have the surgical skills workshop every week on Sunday at 5 p.m. Check out all of these events on the event sign-up form and sign up for these events, and I hope to see you there. I'm still looking for applications for my committee, and I encourage everyone to apply, no matter how long you have been with BMSA. I hope everyone has a wonderful week.
Hello everyone, my name is Tristan Ibarra and I'm your medical discussions chair. We have a couple of academic workshops coming up in these 2 weeks. On the 24th, we have a medical ethics at 5 p.m. and medical news hour on March 2nd at 6 p.m. We have on March 9th a new workshop called Medicinal Policy, Integrating Ethics, Law, and Medicine at 6 p.m. The Zoom links will be provided in the sign-up form. Also, just a reminder, applications are still open for medical discussions. If you're interested, please apply by Friday the 26th. Thank you.
Hi everyone, my name is Jessica Fan and I'm one of your Global Health co-chairs this year. We've got a few awesome workshops coming in the next couple of weeks. Global Health Outreach is on Tuesday, March 2nd at 5, and Clinical Skills, which is back this semester, but the first workshop is going to be on Friday, March 5th at 5. We've also got Medical Spanish on Monday, March 8th at 4:30. Daniel's going to talk a little bit more about mission trips and committee applications. Check out the sign-up form for all of these amazing events I talked about and more. Thank you.
Hi everyone, my name is Daniel Jones and I'm one of your Global Health co-chairs this year. I wanted to let you all know that we also have a World Health Organization workshop on Thursday, February 25th at 6, where we will be talking about heart disease. So be sure to sign up for it on the event sign up form if you're interested. I also wanted to give you all an update on the mission trip this year. So as of now, we will still be going to the RGV in May. If you're interested, check out the trip page on the BU Missions website. And if you have any questions about the trip, feel free to contact Jessica or I. Finally, just a reminder, applications are still open for the Global Health Committee. So if you're interested, then please apply by this Friday. Thank you.
Hey everyone, I'm Jasmine and I'm the Community Outreach Chair. We've got an exciting donation drive and workshop coming up from February 21st to March 12th. We're gathering donations for Street Talks with St. Peter's Church. These donations will be given to those experiencing homelessness in Waco. In a bag, please donate deodorant, hand sanitizer, a pack of wet wipes, travel toothbrush, and travel toothpaste of any size. These items can all be found at the dollar store. And don't forget to include an encouraging note to brighten someone's day. There will be a BMSA COIS donation box located in the BSB atrium, and please label your donation with your first and last name on a sticky note or something of that sort. as well as sending me a picture of your donation for points. My email can be found on the BMSA website. And COIS really appreciates your help in serving the local Waco community. We also have a Zoom cooking class on March 4th from 6 to 7, where we'll be teaching healthy and easy recipes for the busy college student. So be sure to check that out on the sign up form.
Hi everyone, it's Pardis, your fundraising chair. If you're a creative thinker, have a passion for fundraising, event planning, or even creating new merchandise, then you should apply for the fundraising committee. Applications will be due this Friday, February 26th by 11:59 p.m., and interviews will be the following day on the 27th. In addition to that, we will also be passing out general member shirts in the BSB atrium between March 1st through 5th, and we will also be announcing pass out times very soon, so be on the lookout for that. Thank you.
Hey guys, what's up? It's George, your social chair. I just wanted to remind y'all of a couple events that are coming up. There's small groups tomorrow at 5 p.m. on Wednesday. Next week, we have our social workshop on Monday at 4 p.m. and medical TV show night the following Friday at 6 p.m. I also want to let you know that I'm still accepting applications for the social committee, which will be due this Friday by midnight. You can find the application on the website and email it to me when you're done. So go ahead, don't be shy, go apply.
All right. Well, hello, everyone. My name is Cameron Campbell. I'm the BMSA Vice President. Thank you all for joining us today. As you can tell, the format for these meetings are still online due to the COVID rules that Baylor has put in place that we are happy to abide by to decrease the spread of the virus. But something that the virtual setting has also allowed us to do is have some guest speakers that we would not normally have. And so today we have a very special guest speaker with us, Dr. Randy Hurley. He is a practicing medical oncologist in Minnesota, amongst many other things that he will tell you about. And he's going to present to us on the world of hematology and oncology, as well as global health. So thank you so much for taking the time to join us, Dr. Hurley. We're excited to have you, and you may take it away.
So thank you, Cameron, for that introduction as my slides are pulling up. As Cameron mentioned, I'm a medical oncologist at Regents Hospital in St. Paul. And when I was invited to do this talk, Cameron had kindly sent me a video of a most recent talk that you'd gotten from Dr. Megan Lisa Geiger. And I really enjoyed that talk, and that it gave, I think, you a great perspective of what it's like to be a newly minted physician out in residency for 3 years. I've actually been out in practice now for 25 years, so I'm going to give you a little bit of a different perspective of, as I get towards the tail end of my career, are there any tips that I can give you or things I found helpful along the way? And hopefully you'll find that's helpful too. Next slide. So I am the medical director of the Health Partners and Regents Hospital Cancer Care Centers. This is a picture of Regents Hospital in St. Paul, Minnesota. Health Partners is integrated not-for-profit healthcare system. If you are familiar with the term HMO, Health Maintenance Organizations, this was a health maintenance organization many years ago that has evolved into a consumer-governed, not-for-profit healthcare system in the Twin Cities. Regents Hospital is its largest hospital, but it has 5 other hospitals that we run cancer programs out of in the Twin Cities and Western Wisconsin metro area. It is a level 1 trauma center, meaning that all the major trauma, gunshots, other sorts of things that happen in the metro area come to this hospital. So you can imagine that alone provides for a real diverse set of patients that come to our hospital. We, of course, have, since we are really about 3 blocks from the state capitol, we have fully insured, affluent patients coming to our hospital. We have indigent patients coming to our hospital. In fact, our hospital does the 2nd largest amount of charity care in the state of Minnesota as a not-for-profit health maintenance organization. We have rural patients from Western Wisconsin that visit our hospital. We have a large population of foreign-born patients. Back in the 70s and 80s and 90s, Minnesota was a popular place for Cambodian and Hmong immigrants to resettle after the Vietnam War. So we have a very large international population here. We have a large Northern African population, Somali and Ethiopian. So a very, very diverse patient population here. And the University of Minnesota's Global Health program essentially evolved out of our internal medicine program here at Regions Hospital. We are an affiliate teaching program for the University of Minnesota. So our hospital has programs for University of Minnesota medical students, internal medicine residents. We have an ER residency here, a psychiatry residency, and our cancer care center is a training site for hematology oncology fellows from the University of Minnesota. So as the medical director of this cancer care program, I do a bunch of things. I do quite a bit of patient care. I have 3 full clinic days a week. I probably see 50 to 60 patients a week in those clinics. I'm involved in some teaching. I used to teach part of the second year medical school hematology course for the University of Minnesota. I also do some continuity of care clinics for our hematology oncology fellows. I do some boot camp lectures for the hematology oncology fellows, and I teach in the global health pathway. I do a lot of mentoring. I've mentored pre-med students, medical students, and hematology oncology fellows for the past 20 or 25 years. And then, of course, a part of my time is administration, kind of running the cancer program here and the 6 other cancer centers that we provide cancer care at in the Twin Cities and Western Wisconsin area. Next slide. So the question is, how did I get here? How did I get to Regions Hospital in St. Paul? Well, you know, I actually grew up outside of Milwaukee, Wisconsin, and I graduated from high school in the late 70s, and really graduated from high school not really knowing what I was going to do, and started taking classes at a community college just outside of Milwaukee, and did my first 2 years of undergrad there. Transferred to the University of Wisconsin in Madison after that, initially thinking I was going to go into chemical engineering. I had a little bit of an affiliation for chemistry and thought, well, I'd go into chemical engineering. But had a friend of mine who was in pharmacy school, and I elected to go into pharmacy school. And at the time, the University of Wisconsin's pharmacy program was an undergrad program that was a 5-year program, 2 years of kind of initial classes and 3 years of pharmacy school, and then a 6th year that was an internship year. And so after my 2 years at the community college, I entered pharmacy school at the University of Wisconsin-Madison, did my pharmacy school work, and as a pharmacy student, got a job as a pharmacy technician at the University of Wisconsin hospitals. And kind of interesting, back in that area, there was a nursing shortage. So at the time, pharmacy took over a lot of the drug delivery in the hospital. And so as a pharmacy technician, I actually had a job giving oral medications, so pills and capsules, to patients. Really a unique kind of thing for pharmacy to do way back in the early 80s. But it gave me a taste of patient care and interacting with patients, and something I just kind of gravitated to. And so I finished my 3 years of pharmacy school and worked as an intern at the University of Wisconsin Hospital as an inpatient pharmacist on the wards. I would round with the doctors, see patients, make recommendations regarding medications. And after finishing up my intern year, I got a job as a inpatient hematology oncology pharmacist. And so kind of at the time, there weren't really extended clinical programs for pharmacists. The whole concept of a PharmD program was just evolving. And so as I was thinking about what other clinical activities I could do, I had another friend of mine say, hey, you ought to go to medical school. You already have all this great background and training. Why don't you take the MCATs and go to medical school? And that's essentially what I did. I took the MCATs, applied. The only place I applied to was the University of Wisconsin. I got into medical school there. I continued to work as an oncology pharmacist part-time on the weekends for all 4 years of medical school. It was great when I was a third-year medical student. I was doing my hematology rotation on the inpatient hematology ward, and on a Saturday from like 7 a.m. to about 2, I'd be the medical student. At 2:30, I'd be at the pharmacist on ward till 11 p.m. and come in the next day and do that on. So it was really kind of, and then of course I married one of the nurses there, and so she and I have been married for 35 years. I've married a hematology oncology nurse. I did my internal medicine training at the University of Wisconsin and a chief resident year. And you can imagine after all this work as a hematology oncology pharmacist, I kind of just gravitated into hem-onc. And it's one of those things that you don't know whether you like something because you're already good at it. In other words, I had a pretty extensive background in hematology oncology as a pharmacist, or if you are good at something because you like it. You know, in other words, kind of why did I drift into hem-onc? You know, I had a bunch of great mentors along the way. The chief of medicine at the time was a hematologist, and he kind of took me under his wing. The chief of hematology was my attending as a internal medicine resident. He invited me to work in his lab as a medical resident and as a chief resident. And it became pretty natural for me to continue on into a hematology oncology fellowship. I moved to Minnesota to do that and did a 3-year hematology oncology fellowship and did a 4th year of fellowship that was primarily a research and teaching year, and then came into clinical practice 25 years ago here at Regions Hospital. Next paragraph. So I threw in a couple case studies to kind of talk about at the urging of Cameron. And this is one that essentially from about a month and a half ago, the day that Cameron sent me this email, this was a case I had in clinic that day. A 58-year-old woman I was seeing who had a history of something called aplastic anemia. That is an immune condition where your body creates an immune attack on its own bone marrow and essentially leads to a low white count, low hemoglobin, and low platelet count. That it can be effectively treated with immunosuppressive therapy, and indeed she underwent immunosuppressive therapy a number of years ago, and now her blood counts, for the most part, were normal. However, over the past year or so, her hemoglobin had been dropping. She had been developing anemia, and I looked at her peripheral blood smear, which is shown here, and what you see these red cells here. You see a lot of small purple dots, which I'll tell you is just precipitated stain on the smear, not to pay attention to that. But you might notice that a couple of these red cells are a little bit larger and a little bit more purple colored. Can you tell that from the photomicrograph? And those are actually reticulocytes. So the problem here, or I'm sorry, the reticulocytes are young red blood cells that have been newly minted from the bone marrow and released from the bone marrow. And so her problem with a dropping hemoglobin was not the inability of the bone marrow to produce red cells, because there were plenty of these young red cells, these polychromatic philic cells in the peripheral smear. So her body was producing more red cells than it needed. The problem was that she was actually consuming or destroying her red cells faster than normal. And there's a particular condition, a really interesting condition called paroxysmal nocturnal hemoglobinuria that can be seen in about 10 or 15% of people who have had aplastic anemia. And next slide. Paroxysmal nocturnal hemoglobinuria, very interesting illness in that it is a point mutation in a phosphatidylinositol glycan linker, a GPI linker. It's a particular mutation in the proteins that link other proteins onto cell surfaces. And the reason I present this is that it just shows you the incredible complexity of the biology of our bodies, and how a point mutation in this particular protein can lead to a bunch of interesting clinical phenomena where red cells lose the ability to defend themselves from certain proteins in our blood called complement. And so the bottom line is our red cells have proteins on them called CD59 and CD55 that help prevent complement attack of red cells. Complement is a protein cascade in our body that is activated during bacterial infections, and so what happens is patients who have this abnormality in this GPI linker have an inability to defend red cells from complement attack and lead to a chronic hemolytic anemia. So this was a diagnosis that I was easily able to suspect just by looking at her blood underneath the microscope, confirming that with a process called flow cytometry, a specific process where we can look for these proteins on, or the loss of these proteins on red cells, and now has a specific treatment. We have a specific treatment called eculizumab that can actually inhibit complement and prevent further red cell breakdown. So kind of a really brief introduction to the complexity of medicine and how the science behind medicine really helps us lead to treatment of patients in a better fashion. Next slide. So another quick case study of why HEMONC. And this picture up in the right-hand corner is a picture of a young woman by the name of Karen Wyckoff. I first met Karen Wyckoff in 1999 at the age of 21. Her parents brought her to me. She was a senior at a college out in Oregon, and about a year prior to that had a mass underneath her arm, an axillary mass resected by a surgeon in Oregon. And they thought that this mass was a benign fatty tumor, but this mass had grown back. And in reality, what it was a malignant cancer called synovial sarcoma. So this mass had grown back from underneath her arm. It had been removed by a surgeon in our system, and she was brought to me by her parents to figure out what to do. And I'll tell you, you know, there is nothing as precious as a 21-year-old daughter to parents. And me being a newly minted oncologist, being in practice for 3 or 4 years, I was simply honored that they would, you know, offer her daughter for me to take care of. I got to know Karen incredibly well, and unfortunately, she, despite extensive therapy over the next 3 or 4 years, actually died of her synovial sarcoma. In fact, I was at her bedside. I was in her parents' house at her bedside when she died at the age of 24. But what impressed me about Karen was, even at a young age, her commitment to serving other people. So her degree was in theology, and during her summers when she came back to Minnesota from Oregon, she worked volunteering her time teaching softball and soccer to underprivileged kids in the area. While she was undergoing chemotherapy under my direction, she would hold food drives. Since she was unable to eat because of all the nausea and vomiting, she would hold food drives to have her friends collect food to send to food shelves in the area. And then when it got close to the end of her life, what really irritated her was that there were really no patient advocacy groups for sarcoma in the area, or really even in the country. And so, so Karen made it a project of hers that she wanted to develop a patient advocacy group that she eventually did start, called Rein in Sarcoma. Rein as in reins to a horse. The reason that was chosen was one of her favorite parks in the Twin Cities area had a horse carousel, kind of like a merry-go-round for older people. And she developed this fundraiser for patients, where patients could come and kids could spend the day on this horse carousel as they raised money for sarcoma research. Her parents have been part of that organization. She died 20 years ago. Her parents have kept that organization going, have raised millions of dollars for sarcoma advocacy, and it's now the largest sarcoma patient advocacy group in the country. Next slide. So why HEMONC? This is a picture of our department crew. I'm kind of in the back on the right. We're teaching oncology fellows and others underneath the microscope, looking at blood smears and bone marrow biopsy and other pathology specimens. When I talked to oncology fellows about why I went into HEMONC, I like to use this analogy that this is the best mix of both the art and science of medicine. You've heard that medicine is both an art and a science, and the science of oncology and hematology is absolutely fascinating. I mean, the biology of cancer, the newer treatments we've developed to treat cancer, just fascinating. But the bedside, day-to-day management of people with a serious illness is incredible art. I also think about essentially oncology is internal medicine cancer patients. So you use all of your internal medicine skills trying to take care of patients with cancer. You develop longitudinal relations with people and their families that can last decades. I also like to think of this concept of great science and great suffering. So you're using both your left brain and your right brain. The great science we talked about, but we are working with people at an incredibly challenging part of their lives when they're dealing with incredibly serious illnesses. I oftentimes say that if I just wanted to do great science, I would have worked in a lab. If I wanted to just do great suffering, I would have been a mortician or something. But to be able to combine the both, the same, I never have a day that goes by where I don't think, oh my God, I took care of some incredibly rewarding patients today. And so it's also a field where there's lifelong learning. You know, the field of oncology, as every field of medicine is just growing at an exponential rate, and it requires it really is a commitment to lifelong learning to keep abreast of all the new developments. Next slide. So this is a picture of myself and one of my breast surgeon colleagues, a photograph that was taken for one of the magazines here in town about cancer care. But I would say this, that the keys to a successful career are a little bit different than the keys to a satisfying career in medicine. I really do think that the keys to a successful career are things like compassion, compulsion, curiosity, and communication. You know, your previous speaker, Dr. Leszek Geiger, had an excellent kind of idea to promote to you that whether you graduate at the top of your class or the bottom of your class, you're still called a doctor. And to have a corollary to that is to have a successful career in medicine doesn't mean you need to graduate from Harvard Medical School. To have a successful career in medicine, you have to have compassion for patients. You have to have compulsion. You have to make sure you follow up on tests, read about things, be compulsive on checking on things. You have to be curious about patients. You have to be curious about what could be going on with them and try to read and learn and think about their illnesses and come up with solutions for them. And then, of course, you have to be a great communicator. You need to know how to talk to patients. And as an oncologist, that really is our procedure, our skill. We talk to patients. We don't do surgery. I don't operate on patients or do any procedures. My procedure is really to be able to communicate with people and tell them about serious illnesses and how to cope with those. To have a satisfying career is different, though. You can have a successful career and still suffer from burnout, right? You can have a successful career and still not be satisfied. To be satisfied, I think you really need that coming from that place of gratitude, that really knowing that being able to be in this position, to be dealing with serious patients with serious health problems is really a privilege, and that gratitude is the key to that. Next slide. Next slide there. So I also think it's important to develop hobbies within medicine. Of course, many of us have hobbies outside of medicine, and that's important as well too. But I think it's important to develop hobbies within medicine. This is a photograph of myself seeing a patient with one of the doctors in Tanzania, Dr. Saga, who I've known for about 20 years, a little kid who had meningitis who recovered from that. The two hobbies I've developed over my career, one is a little bit about leadership. So I did a certificate program in management for physicians at a local university a number of years ago. My advice to all of you interested in going into medicine is to learn some leadership skills, read some leadership books, those sorts of things. You will eventually, in your medical career, be a leader whether you like it or not. In other words, as a medicine resident, you will have nurses and dietitians and pharmacists and others that you'll have to work with. And because you're the MD, for some reason, you're depicted as the leader, even though you may have no leadership skills. And so really, your goal as a leader is, how do you help people become the best at their jobs that they can be, whether that's a nurse or a medical student or a pharmacist or a dietitian or a nursing assistant. So how can you develop those leadership skills to do that? The second hobby I developed in medicine was, of course, tropical medicine. And so that story started, my daughter, when she was like 8 or 9 years old, really wanted me to take her to Africa. I don't know, she was watching one of those Saturday morning infomercials about, feed my starving children, those sorts of things. But she was so darn persistent about, Daddy, when will you take me to Africa? Can we go to Africa? I'm like, sure, honey, one of these days. I was sitting in church one day and I read it, I was kind of in the back pew, kind of just, doing whatever I do and reading the church bulletin, and they were looking for volunteers to develop a companion congregation relationship with a particular village in Africa. And I'm like, something clicked. I'm like, gosh, we're going to do this. And so a year later, I found myself and my family and 6 other people from our church on a plane to Tanzania, Africa, to visit a small companion congregation village. And as a physician there, kind of tapped into the type of healthcare that is provided there, and kind of got interested in travel and tropical medicine. Actually did a certificate course at the University of West Virginia, of all places, in travel and tropical medicine, and have had that be part of my career for the past 15 years as well. Next slide. Another case. This is, again, a case just this past month showing how a knowledge of tropical medicine actually helps me in my career here, taking care of patients in St. Paul, Minnesota. So last month I saw a 57-year-old Somali immigrant who has had a long-standing history of pancytopenia. So once again, a low white count, low hemoglobin, and low platelet count. He'd actually seen a number of prior hematologists and a prior gastroenterologist. We knew he had an enlarged spleen. The spleen is an organ underneath your left rib cage that is part of our immune system. People who have enlarged spleens usually have low blood counts because that spleen, simplistically speaking, kind of acts like a sponge and kind of sequesters white cells and red cells and platelets in the spleen. That enlarged spleen appeared to be due to portal hypertension, so a problem with blood flow and plumbing through the liver, leading to expansion of the portal veins and congestion in the spleen. In our country, most portal hypertension is due to liver cirrhosis, and most liver cirrhosis is due to alcoholism or something called non-alcoholic steatohepatitis. Well, this gentleman was a Muslim immigrant. I knew he didn't drink alcohol. He was not obese. He didn't have steatohepatitis. He really didn't have cirrhosis at all. I knew he came from an area of East Africa that is endemic for a particular helminth infection called schistosomiasis. Schistosomiasis is a type of helminth infection that is transmitted by snails. These small little eggs and worms are taken into the body and can lodge themselves in the portal veins and lead to portal hypertension, splenomegaly. And so a simple serologic test led to a diagnosis of schistosomiasis, and so we are treating for that and can potentially cure him of this. Next slide. So what I like about tropical medicine is it kind of complements my hem-onc knowledge. So there's that intersection of my hem-onc knowledge with my global health knowledge, and it actually, I think having a hobby outside of hem-onc probably makes me a better hematologist and oncologist. I certainly know how to take care of immigrants with cancer, and I know the types of blood disorders that are more common in immigrant populations. Next slide. So up on the upper left-hand corner is a map of Tanzania, Africa. You can see that that is in East Africa. It's bounded by Kenya on the north, by Mozambique on the south, and by the Democratic Republic of the Congo and Rwanda on the west coast. If you probably can't see this very well, but right in the center of this map of Tanzania is this large national park called Ruaha National Park, and a little town called Iringa that's on the map. When I came to this area of Tanzania, our essential goal was to put a red dot. You see all these other red dots, all these other red names on this map. All those other red names are the other Lutheran-sponsored hospitals in Tanzania. And our goal was to put a red dot by Iringa in that central portion of Tanzania. And that's essentially what I've worked on for the past 18 years, helping to support a hospital in this rural area of Tanzania. That picture to the right is the picture of the maternal child health building in Tanzania, a very busy place. You probably noticed that in developing countries, a lot of the healthcare is devoted to pregnant mothers and children under 5, so busy part of that hospital. That bottom picture on the left is the picture of my daughter when she was 10 on our first trip there, playing with some of the other kids on the hospital grounds. The picture on the right is a picture of me. I'm kind of halfway there with a red shirt, my hands crossed, some khaki white pants. My son is the 5th from the left. This was his Eagle Scout project of collecting medical supplies and shipping them over in a 40-foot container to this hospital a number of years ago. Next slide. So I actually do some volunteer work for 3 different nonprofit organizations. One is our own little nonprofit called alulahealth.org. That is our own little 501c3 nonprofit that we have developed to help support the Alula Hospital in the Iringa region of Tanzania. I also have done some work for an organization called Global Health Ministries. That's that organization that helps collect used and discarded medical supplies from hospitals in the Twin Cities that we can ship over to developing countries. My third project that I've been involved with, and this is the one that Chase has been involved with, is something called FCCT, or the Foundation for Cancer Care in Tanzania, tanzaniacancercare.org. So what we have done with this organization is we have developed a cancer care program at a Tanzanian-based hospital in northern Tanzania. As part of this global health work, we have developed a 6-week interdisciplinary global health course where we take medical students, pharmacy students, medical administration students, and family medicine and internal medicine residents from the University of Minnesota over to Tanzania for a 6-week kind of global health immersion course every January. This January was the first year I didn't do that in 10 years because of COVID-19. That global health course has been shut down temporarily. Next slide. So some thoughts about incorporating overseas work into your career. This is a photograph. This is my wife on the right with the camera around her neck. She is a hem-onc nurse who's been with me to Tanzania numerous times. There's a medical student in the middle and a nurse anesthetist on the left. Kind of think about what the personal reflections or personal motivations are for doing global health work, and deciding whether the work you do is truly relief work. Are you going to this underserved area to see patients, or are you going there to develop their medical infrastructure so that they can do the work themselves? Time is always an issue, and indeed, time is your most precious resource as a physician. You never have enough time for anything. And so trying to figure out time management for this is important. And for me, what has been important is involving my family. In other words, so when I plan to spend 2 or 3 weeks in Tanzania, I always take family members with me so that I'm not taking away from family time. I oftentimes get asked, well, what's the best specialty to do global health work? And my answer to that is, no matter what specialty you're in, there is always someone in the developing world that is doing your type of work that you can get to know and work with and support. And in fact, that does not need to be a medical specialty. So there are teachers over in Tanzania that would love to meet teachers from the United States. There are bankers and finance people. There are farmers. There are electricians. So we oftentimes take groups of medical professionals and their spouses who are non-medical professionals and help them hook them up with community workers to learn best the types of challenges to work over there. If I had to pick one specialty, though, that it would be family medicine, because in Tanzania, many of these are primary care facilities where you see the young, the old, deliver babies. So family medicine would be the most well-rounded specialty. But in reality, any type of specialty with interest could do work in the developing world. I won't talk too much about this, but there's this whole concept of how to help without hurting. That's a whole nother talk in and of itself, and something we can talk more about. I will say this, that my understanding of cross-cultural work, working in Tanzania, has helped me in my leadership role here in Minnesota, because really what we do is always cross-cultural work. In other words, if I am working with another healthcare system, if I am working with the leadership of a rural hospital, that is all cross-cultural work. And knowing the intricacies of cross-cultural work and the pillars of how to do that work well helps me certainly in my work in Tanzania, but even in dealing with other cultures within medicine, even in the Twin Cities and metro area. And I think the last point about this is, as you incorporate overseas work into your medical career, do you go to many places once? In other words, do I go to Tanzania one year, to Jamaica the next year, to Nicaragua the next year, to Uganda the next year, and then to Southeast Asia? Or do I just go to one place many times and develop that longitudinal arrangement? I have an 18-year history of working with the Alula Hospital in Tanzania. So I have we've had, going back to Alula every year is kind of like having a family reunion every year. There are doctors and nurses and their family and their children that know my family and my children, and going back there year after year is almost like a family reunion. And so there's benefits to going to one place many times. Last slide, next one. So conclusions, so this is a photograph of a baobab tree and sunset in Raha Park in Africa. And I guess if I had any conclusions for people or tips, I would say, gosh, what are the biggest problems in healthcare right now? So if you had to think to yourself, what is the main challenge to healthcare in the United States? It probably is that it's too damn expensive. In other words, healthcare costs too much in the United States, and figuring out ways to make healthcare affordable so that we don't have such a large uninsured population is crucial. I think learning some leadership skills, we already talked about that. I think I was blessed by the fact that I had a job in healthcare before going into medical school. That, of course, is not available to everybody, but many people such as yourself get jobs as scribes. I think that is helpful. Another recommendation for myself would be, could you get a job as a nursing assistant? In Minnesota, to get a nursing assistant license, you have to do an 8-week course. I think if you were able to do an 8-week course and get certified as a nursing assistant in your state and actually work in a nursing home or in a hospital where you were actually taking care of patients, so you actually knew what patient care was really like, would serve you really well in the future. We talked about the 4 C's: compassion, compulsion, curiosity, and communication for a successful career. We talked about gratitude as a satisfying career. We talked about the role of developing hobbies within your career to keep you interested in medicine. And then if I had to give you any tips on what to read now, like in preparing for a career in medicine, what should I read, well, don't read anatomy books or other sorts of, the things you ought to read are learning something about quality improvement basics. So healthcare these days is all about quality improvement, and learning the ins and outs of quality improvement basics and how to conduct quality improvement projects would serve you well. Check out the IHI website. The Institute for Healthcare Improvement has a bunch of great online courses for quality improvement. Start reading the New England Journal of Medicine's Perspectives articles. So the New England Journal of Medicine, you're probably aware of. It's a weekly publication that comes out. They always have a perspectives section. And in fact, this week's New England Journal of Medicine has a perspective on whether the medical proficiency tests during your career should be turned into pass-fail tests, or whether they should really be graded on a numerical scale. So last week there was a perspective on religious organizations suing local governments because of COVID restrictions on gathering in faith communities. So as a physician or as a medical professional, what is your stance on understanding our role in medicine and society? I think these perspective articles in the New Journal of Medicine give you a great background on that. You guys are probably familiar with the author Atul Gawande. So reading almost anything that Atul Gawande has ever written, a bunch of books, one called The Checklist Manifesto about quality improvement, another called Better about a way to improve healthcare systems. So anything that Dr. Atul Gawande has written, I would probably read as well. Let me stop there. I'm sure I've gone over a half hour or so, but let me just stop there and see what kind of questions you guys have.
Wonderful. Thank you so much, Dr. Hurley, for that very nice and insightful presentation. So now we're going to transition over to our Q&A portion of the presentation here. Let me just pull up our questions. And so you actually answered very well the most common question that we get asked, and that's kind of the advice that you have for aspiring doctors, the advice you have for pre-med students, which I thought was very good take that you had a lot of other people haven't mentioned, because a lot of people think you need to read anatomy books and stuff like that. And so I really appreciate that perspective. But one question we'll start off with is from Michaela Olson from Bedford, Texas. And they ask, what is one major difference between cancer patient care and treatment in the US versus in Tanzania?
Yeah, so a great question. People don't know this, but more Tanzanians now die from cancer in Tanzania than most of the other issues such as TB, malaria, even HIV. Much of the cancer in Tanzania, however, is HIV related. So cervical cancer, that's HIV related, lymphoma, that's HIV related, another cancer called Kaposi sarcoma. The real difference there is the lack of infrastructure and resources. So late stage of presentation, patients aren't aware of cancer. They are not aware that a mass in the breast could be cancer. It's oftentimes treated as an infection for months before a mass in the breast is really thought, gosh, this isn't an infection, it's actually a cancer. So late stage of presentation, lack of patient community and physician awareness that's about a presentation of cancer, and then lack of facilities to treat cancer.
Very good. And so I do have to give a quick shout out to our BMSA members, because this was the most submitted questions that we've ever had. We had around 60 questions submitted. And so thank you all who submitted questions. Unfortunately, we can't get to all those today. I would love to. But let's see, our next question that we're going to have comes from, let me see, comes from Abigail Yarbrough, who's a health science studies major from Round Rock, Texas. And they ask, how do you recommend overcoming language barriers when working abroad?
Yeah, so I have learned a little bit of Swahili, enough Swahili to ask basic and simple questions, but we use interpreters. So we have nurses and other students. We'll have high school students that speak good English work as interpreters for us. So we really have to have a very well defined interpreter service. Many people in our country are already bilingual, have Spanish as a second language, can easily go to Spanish-speaking countries and be fluent. I am not fluent in Swahili. I know enough Swahili to be conversant, but I really need an interpreter to, in other words, I can ask questions, but if a patient tells me more than a yes or no answer, it's hard for me to interpret, so I need interpreters working with me. Great question.
Mm-hmm. And so this next question, I feel like is very important and one that I think a lot of times as well. This comes from Asan Lehara, or positive patient outcomes or negative patient outcomes, and also how do you stay positive in a field that is oftentimes leading or dealing with incurable cancers, and does that take a toll on you?
Yeah, so that's actually a great question. So you know, we do deal with a lot of grief and suffering. And that is a difficult thing. And as you can imagine, there's a blessing and a curse to everything. The curse is that you deal with a lot of suffering. The blessing is, you know, each one of your patients you see, you know they are there because they need you. And people who take care of cancer patients, whether those are nurses, pharmacists, physicians, nurse practitioners, PAs, they have this really deep down commitment that they want to do everything they can for their patients. So we don't suffer that type of burnout, that sense of, gosh, these patients are just, you know, in other words, every patient needs you. However, on the other hand, dealing with that type of suffering on a long-term basis certainly has changed me. I am not the I don't a practical thing. I'm not that interested in going to big parties anymore, where people get upset over frivolous things. So you know, when people complain about frivolous things, I think to myself, damn it, it could be worse. You could have stage 3 breast cancer, blah 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 blah. You know, I mean, so it helps me put everything in perspective. And you know, I have become more family oriented, a little bit more spiritual. I don't know. It's helped me in a bunch of ways, but definitely has changed me.
Wonderful. And so, as I was trying to set up all the technical things on my screen, I kind of missed your introduction. But you mentioned that you went to community college first, correct?
I did, yes.
Okay, and so I always think that that's a very unique experience, because I also transferred from a community college. And so you've had plenty of experiences, you've done many things in your life, and it's all turned out amazing. And so what advice do you have for high school seniors contemplating whether or not to go to a 4-year university or start off at a community college, and how has community college shaped you as a doctor?
Great question. So, you know, I think the key is being somewhere where you can learn. You know what I mean? So whether you go to a community college or a 4-year college, you want to go somewhere where you can learn and be successful. What I loved about a community college is I had all professors teaching my classes. I didn't have TAs. I had access to my professors all the time, and so I was kind of living at home at the time, and so I was really I was in a setting where I knew I could learn, and I was very successful at community college. I came out of there with with a great grade point average, which helps me with the next step, which was getting into pharmacy school. And so I think that really choosing a place to go should be not so much about the name of the place. In other words, do I need to go to Harvard to get my undergrad degree? Well, I need to go to a place where I can learn and become really good and learn this foundation so that the next foundation of knowledge I get, I can build on. The same as with medical school, so nobody asks me, where did you go to medical school or where did you go to residency? They don't want to know that. They want to know, are you a good doctor? And do you know what you're doing? Do you care about me? You know what I mean? So.
Absolutely. Thank you so much for that answer. And so we have time for 2 more questions. And the next question, they're kind of synonymous. This comes from Rachel Hurley, neuroscience major from Mission Viejo, California, and Zachary Fitzgerald, a biochemistry major from Boston, Massachusetts. So they ask, is there a specific reason that you chose Tanzania as a location to support your program when not directly practicing in the United States? And can you also describe how the medical system in Tanzania has changed since your first visit to the country?
Sure. So as I mentioned, getting involved with Tanzania was just one of those happenstance things. Me responding to a call in our church bulletin to develop a congregational relationship in Tanzania, and a daughter wanting me to take her there, and then going to Tanzania and think to myself, gosh, I wonder how I can help their healthcare system here. So choosing Tanzania was almost chosen for me, so to speak. You know what I mean? But keeping my eyes open to, gosh, how can I help? What can we do here? Was just one of those phenomena of visiting a place and asking and developing relationships, getting to know the people you're working with, and asking how you can help. There has been quite a bit of a change in the healthcare system over the past nearly 20 years that I was going there. So when we first came to Tanzania in 2002, Tanzania had an incredible HIV outbreak going on. The hospitals were full of HIV, but there was no way to diagnose it. There were no tests for HIV. There were no drugs for HIV. It was just crazy. This was. Remember, the HIV virus was identified in 1985, and the first drugs to treat HIV in this country came out in the late 80s. This is a full 25 years later, and there's no testing, no drugs, no treatment. It was crazy. In fact, in Tanzania, we didn't even use the term HIV because there was so much stigma around that it would cause stigma in the community. Within about 3 or 4 years of us working there, we were able to help develop an HIV program. It was another one of those serendipity kind of things where the Clinton Foundation brought an HIV program. They essentially found our little hospital and brought an HIV program to that hospital. And so now that has a fully functioning HIV program, we've been able to add a surgery suite, add improved wards at a nursing school and a clinical officer school, add X-ray and ultrasound capability. So, and all this has been by training local Tanzanians to take charge of their own facility. So it still is a ways behind modern medicine in the United States, but the Tanzanians are doing incredibly well with the resources they have.
Very interesting. I think it's very funny that Tanzania was chosen for you because as the questions that I saw reading through there, a lot of people are very interested in going abroad, and I guess they want to find out how to do that and stuff. So it's very funny that that's how that worked out for you. And so my last question for you, so you've been studying cancer for many, many years, and in your expert opinion, do you think that there will ever be a true cure for cancer?
Well, gosh, that would be a wonderful thing to think about and hope for. I think that, Likely not. I think that we will become much, much better at controlling it and turning it into a chronic illness where people can live years and years and years with it. But the biology of our human bodies is so complicated, so complex that and cancers are such a diverse population of illnesses that finding one uniform cure that will likely treat the plethora of different cancers out there, kind of hard to think of. I do think that we've made a lot of great strides into turning even advanced cancer into more of a chronic illness, one that can be controlled for years with different types of medications. Right now, we're in kind of the immune therapy era of cancer care, where in the last 5 to 8 years, a lot of strides have been made in harnessing our own immune systems to control and keep cancer in check. And so I hope that will continue to be built on.
Wonderful. Well, that concludes our Q&A session. Thank you so much for joining us, Dr. Hurley. It was a pleasure getting to speak with you, and hopefully we may have you on again. From myself and BMSA, thank you for everything that you do in the world. And also thank you for everyone watching at home. We had so many question submissions that we couldn't get to all of them, but please continue to submit your questions and we will ask them for our next guest speaker. And always keep yourself and Waco safe. Thank you very much.
Thanks for tuning in. Leave a comment below or contact the officers if you have questions, and subscribe to the channel if you haven't already. Be sure to follow us on all social media to keep up with all the fun.